Good morning. I want to discuss today how 3D printing had evolved a little bit in our team and how we've been using it for potential practical applications in spine. So I was going to give a little bit of background about, what 3D printing is, how it started off in the last 10 years, and why the last 2 years it made significant progress. I wanted to thank James Caruso for helping with that talk. Part of it is what was presented for us at the Rocky Mountain Neurological Society meeting. So what's 3D printing? It's basically a way to make complex objects that can be done in different manners. The most two commons to 3D print can be either resin-based, which is the picture on the left, where you build the object from the top down, or it can be extruder-based, where you basically push fluid or plastic through a filament to build a complicated form. This is just a simplified rendition, but it's the two main ways we can 3D print, whether it's plastic, metal, or different materials. The materials that can be used can range from plastic to industrial grade nylon to metal. It can be flexible, dissolvable, UV resistant, water resistant, edible, or food compatible. And each one of these filaments have different characteristics, such as the printing temperature, the strength, the durability, how difficult it is to make complex forms with it, and whether or not it can be painted or made adherent to other materials. And when people think about 3D printing, they think about this. This was the main use of it about 10 years ago to up to 2 years ago, printing toys with high accuracy. But today, it's being applied across a range of multiple fields. 3D printed houses are a reality just because it doesn't need a solid foundation. It can be set up in about a couple of days. You can print the whole complex. It can be complex buildings too, such as hospitals. This is in the Middle East somewhere where they print a whole hospital complex in about a week. The Army and the military are using it to 3D print parts of hardware so they don't have to ship it. So now you have capabilities on the battlefield to replace engine parts or armament. And then whether you agree with it or not, they're 3D printing steak now. So you can have 3D printed meats that simulates the actual thing without having to kill the animal. But in medicine so far, up until 2 years ago, it was more of a exhibition type of modeling. One of my mentors, Dr. Bendock, used to 3D print aneurysms for patients when they come in with a complex case, when the aneurysm was, high intraoperative rupture risk, and we'll give them the model. And that was about 10 years ago. So it's been around for a while. I know in endovascular, they can 3D print the entire vascular body for educational purposes. And there's even publications in spine where they 3D printed the spine, not necessarily specific to a patient, but for resident training purposes to put in pedicle screws. And we've tried to take it a little further. Today, they 3D print implants. So the surface of the implant that's micro-etched to mimic trabecular bone and help in osseointegration. That's a fact. We've been using them for the better part of a year. In orthopedic surgery, they're having experimental 3D printed custom-made parts for osteoblastoma for kids. And that spine model at the bottom right is actually something that came out about a year ago in China, where a surgeon 3D printed a axis, so the C2 vertebrae of a child, to allow for motion preservation. It's an anecdotal report, but it shows how we can progress towards replacing parts instead of fusing parts. So as a department, we're using this for complex surgery and also MIS. So for deformity correction, it'll help us plan our osteotomies better, how we're going to derotate the patient if it's a really complicated deformity, especially if they have aberrant anatomy. A lot of them do, like 6 lumbar vertebrae or an aberrant L5 to S1 connection. It helps us plan how to place the hardware. And the difference between having the model 3D printing and just using the O-arm or navigation during surgery is the fact that you can plan where to start your screw point, not just how to cannulate the pedicle. And we're getting a robot soon that's going to help with that as well. And it also helps the patient to understand the scope of the surgery they're going to undergo. Because when they see their deformity, they can hold it in their hands, they're way more likely to be vigilant about their postoperative care, understanding that, these are some certain things they can do. They can, be going golfing right after surgery or fly fishing, even though they feel well. And a more recent application of 3D printing was MIS to help us in patients with complex anatomy, and we'll see a case, how to place the tube, how to direct themselves, because there's a couple cases we actually went back and forth in the OR to the model to see how to direct our surgical approach. The 3D printers that we use are commercial grade. They're affordable today. It's about 5 or 6K. So for an institution, it's affordable. These are the parameters that we use. So, and whenever you 3D print a model, you start with a 3D reconstruction of the model that get made into a file that's called an STL file, and then goes to a slicing software. The slicing software you usually get with the printer, so they're usually paired. It's gonna divide the model into several layers, and then you send it to the 3D printer. And you can decide on the size of the layer, the size of the filament you're going to use, the temperature of the filament that's melting and of the chamber that you're printing in, the printing speed, the thickness of the layer, and what you fill the model with. Is it going to be empty? Is it going to have a beehive kind of pattern inside? What is the overall density? So just to show what we've done, this is I'm going to present 3 cases. The first case is a 62-year-old man that we saw at Parkland 5 years after trauma. He had a fractured dislocation at T12, L1, L2. They actually never got treated for, and he fused in kyphosis. He was progressing his kyphosis to the point where he couldn't stand for more than 4 minutes. He was stooped forward, and you may have seen him walking around Parkland with his bicycle underneath his armpit. So he's very functional despite that deformity, but he progressed to the point where he couldn't breathe because his pelvis was engaging under his ribs. So these are Scully films that we got at Parkland. We didn't have a Scully machine there, so it's 2 superimposed images. And I used to think that the AP was actually misaligned, but it's not. That's actually how he looked. And you can see how his pelvis is engaging under his ribs. So it's giving him reflux. He lost weight. He couldn't breathe. So we 3D printed that model. And as you can see from the model, between the difference between the model and the scoliosis film, he reduced quite a bit laying down, because that model is printed through CT scan images. So just laying down without the effective gravity actually made half the job for us. And we're able to reconstruct him and plan our main rod, auxiliary rods, and he's been out for about 2 years now. And last I heard, he went to Atlanta to get married, so he's doing fairly well. And we even printed the screw complex to see if we could showcase that to the patient. And I think he was appreciative of that when he saw it.
Well,
Yep. Go ahead.
So how did the 3D printing help?
So for him, he understood the scope of what was going to be done to him, because no matter how many times you tell the patient, they're not going to understand that they're literally being cut in half for that surgery to happen. He was more cooperative with his rehab, more cooperative with wearing the brace. And for us, it's really hard to orchestrate how we're going to derotate the patient just looking on images. Because to make this into a somewhat straight line like we did there, there's going to have to be some planning of screw placement so that they align at the end without over torquing the screws. Because it's very easy to just put them blindly based on imaging, and then you can't put the screws to the rod. The rod is not a straight one. They end up having the same deformity, just fixed now. Also helped a lot with placing our accessory pelvic bolts, because we use 2 rod constructs there, and to plan our connectors in a way that's going to allow placing them to basically brace the inflection point that he had right here in the middle. So just studying that beforehand helped a lot.
I don't mean to keep drilling.
No, go ahead.
So you said helped a lot, like 4 times.
I think.
Elaborate, like how did it, like, how did you look at it? How do you look at this differently? I mean, there are people who do it without it.
Correct.
So what are where do you think you get the advantages?
I think that correcting the formula like that in a way that's not going to fail repeatedly is hard to do if you don't have a good grasp on the anatomy. And this patient, the 3D model is what really showed us how that fracture dislocation was fused wrong. It's not something we fully understood on the 3D model of the CT scan. And unless, I think we do 500 of these, it's not going to become second nature. I think especially for early surgeons that, are starting their practice, it's very useful. It gives us an advantage over experience. I really believe that, because then you can put the model in front of you, especially if it's life size, plan your trajectories in a way that's predetermined instead of making that call on the OR table, which is what happens in most cases. That was very useful to me personally, to correct them in a way that doesn't feel like we're just making up a plan in the OR because we're just looking at the element in 3D for the first time.
I have similar questions. Does it help you plan, can you get an idea of what the rod bending is supposed to be? Is going to be?
Absolutely, because what it showed us between that and this is how much correction he had. It also showed us which segment were mobile. And you can see here on the right side of the picture, he was arthrodesed there, so end up doing gill lamis at that point. So doing gill lamis there allows us to mobilize that segment really well. And then it allows us to put a curve rod and then derotate in the surgeon, and that's what brought him to the middle.
So looking at the 3D model, you said, okay, this is where we're going to cut.
Exactly.
And so we know that the rod will have to be F shape X.
Correct. Correct. There's a lot of adjustment in situ that happens still, but it was definitely very helpful. And the next case is even more representative because we brought the model into OR.
Reduces rod bending.
Yeah. Yeah, absolutely. And in these cases, honestly, if we bend it too much in situ, it doesn't matter what kind of material it is, it weakens the rod, and you end up bending the rods repeatedly at the weakest point, which is the inflection of the spine, and then they break there. Especially the longer you go, the more the torque is going to be, so they end up breaking harder. The second case is similar, but he's a gentleman with Parkinson's disease. His Parkinson's was fairly well managed. He had an epidural steroid injection because he had the degenerative scoliosis, and he got an infection from that, epidural abscess. He lost the function of his lower extremities. We took him trying to do minimally invasive treatment initially with a hemi-lami. He recovered all his motor function, but as we know, when you decompress the apex of the curvature, which we didn't have the choice at the time, you can significantly worsen with time your scoliosis, especially your kyphosis. And he did that, wasn't able to ambulate more than 20 feet at a time, and he started having GERD, breathing malfunction, because also the pelvis was engaging under the ribs. And that was him right there. And the coronal plane is not as bad as the other one, but he's worse in the sagittal plane. And we 3D printed him in actual size. And in the model, you can see where, on the second picture from the left, where we had the prior laminectomy. It's like a mini lami trying to not mess up with the joint as much as we could. But he progressed despite that. And his deformity didn't reduce really as much as the other one because it was non-traumatic. So it was in the OR. It matched his parameters pretty closely. And that's him after we did our exposure. You can actually see prior laminectomy size that matches the model. And especially in him, planning our secondary rod was important because he had 6 lumbar vertebrae and an aberrant L6-S1 junction. So that was useful to know beforehand versus just experimenting with the arm when we were in the operating room. And we gave him a fairly good correction. He was happy. He gained back the weight that he lost. So that's really what it does. It gives you foresight before going into the OR. And it makes, approaching these kind of deformities a little more palatable versus, going in not knowing what to expect or where to put the screws in.
That's obviously a big operation. It takes a long time. Do you think the model helps you shave some time off of it?
Absolutely, 100%. It takes away the hesitation, I think, from the OR because you've already thought about it before. So instead of taking 9 hours, it's taking 5 hours because you know where you're going, you know what you're going to do. It's just a matter of making it happen. I 100% think it shaved off at least a quarter of the time.
Has anybody, imagine, I'm just thinking when I used to build model airplanes and stuff. how like it comes in like a plastic tree.
Mhm,
Like the individual parts are connected by like a small piece of plastic to the overall tree.
mhm.
And you just kind of cut it out and then you have an individual component. I imagine you could do something where you like print each bone individually and then put it together using some relatively simple component that would mimic some of the spatial dynamics of what the spine will do following X maneuver,
Yeah,
and then you could see what correction you would get and maybe refashion your rod.
that's what the robot is gonna do for us too, and then we're gonna start scanning it. The advantage of the software compared to ARM, it recognizes the segments individually, and then it allows you to put your screws in, plan the screws, and then move the segments based on how you align them, and even give you a planning for your rod. So it's not just the robot per se, because the robot is just gonna put the screws similar to how you're gonna do with the arm. It's the software that comes with it that allows you to segment the spine a certain way to move. This being said, it's kind of theoretical because all the ligaments and the arthritis, the arthrosis disc, they're gonna limit what you can do without totally disconnecting them. But it's a close approximation, I think.
So the robot has some software that
Mhm.
estimates the mobility of the segment.
Correct, and you can print out of this software the segments individually, because that's how it's going to recognize the patient through X-ray. Because the patient gets on typical X-ray and link that to the CT scan.
This is the measure or what?
Yeah.
So it's going to, the robot will allow you to, it feeds into the 3D printing.
Correct. You can just print out of what he gives you, the output, and then you can print the segments. Because the slicing software is much more advanced than what we use for just 3D printing slicing. The third case is the other end of the spectrum. It's a 40-year-old woman who has had back pain, side joint pain for about 10 years. It responded to injections, but then always recurred. And she had bilateral Bertolatti syndrome. Bertolatti syndrome is where you have pseudo-attachments of the last lumbar vertebra, whether it's L5 or L6, to the sacrum, which creates a joint that wears out and has pseudoarthrosis with time. So the TPs are so large that they pseudo-articulate with the sacrum. And that's not something that's compatible with a degeneration. She had 6 lumbar vertebrae and very enlarged bilateral TPs that were not just a simple connection. It was a 3D connection in space. So this doesn't give it justice, but we have a CT scan coming up. So she's got 6 lumbar vertebrae. On the right side, it's a very large connection with the sacrum. On the left side, it's basically a lengthened TP that's touching the ilium there. And you have 2 options. You either can fuse them or you can disengage the connection, which is the least invasive way of doing it. And then you don't have to go through a fusion. That's your CT scan. You can see on the right side, it's a complicated connection with the sacrum. And the other one, you can see how degenerated that connection is. That was a major pain generator for her. You can see it on both sides, how that looks like. She even have like a calcified cap to that joint over here. We 3D printed her to kind of understand this a little better, and that was very useful in mainly docking our tube and how we're going to direct our tube after we dock, because things can get lost if you're working under the wing of the pelvis. That's really what would confuse us in surgery, is that you're working at an angle that has to get you under that wing, so it's very easy to get lost and go to the wrong spot. And we had that in the OR with us. And it's a zoomed in picture of that model where you're working under the wing to try to disconnect both, especially this one on the right side here. So we did that minimally invasively. You can see the first one that's disconnected here that we did before, and that's docking on the second one. And obviously we confirmed with x-rays, but it went really well. Went back and forth with the model and the OR multiple times. And I think it helped us complete our work in a way that probably would have been partial without it. Even navigation was a little deceiving in that case, just because it gives you sagittal coronal images, doesn't really give you a good 3D understanding of what's going on. So in general, just about the models, it takes 4 to 9 days to produce. You want it in a monitored environment because it's a high risk. The average cost is $20 to $60. So if you're doing a $100,000 scoliosis surgery, it's worth doing. It doesn't take any text to do it. The software is all publicly available that we use. And you're not putting hardware in the patient, so there's not a risk to the person. It's not bound by IRB unless you publish it, and patients so far have had good feedback from it.
Do we print them here or do they?
Both here, and I have one at home.
Oh, you said it's not what or what unless you publish it?
So you don't need to ask for IRB clearance to actually 3D print the model since they have the scan, but if you publish it, you may have to be covered by an IRB umbrella. Questions?